So from the management of cancer point of view, we had to compromise with our treatment protocol, be it surgery or radiotherapy or chemotherapy. So these new strategies will be discussed in today's program, that is cancer management and its relevance in COVID times. For this, we'll invite Rakesh to moderate the session. Before Rakesh takes over, I can add that when we started our career about 43-4 years back, there was not such of importance for management of oncology. Only radiotherapy was there. The surgeon used to send the advanced cases to radiotherapy department, give some dose of radiation, that's all. And chemotherapy was being carried over by the same radiotherapist for pretty long time. Now there are so many divisions in oncology management, basically medical oncology, radiotherapy, surgery, and there is also subdivisions in that. It has progressed a lot. And I am happy to say that among with all disciplines, our brothers and sisters from Nilrathan, they are doing exceptionally well in the field of oncology. There are so many good students and now they are consultants. They are doing well in this field. So I now request Gautam to say a few words before the mic goes to Rakesh.
আমি আর কি বলবো, আমি আর অনুপদা, we are basically from the same genre, and our creator was Dr. Abhijit Basu.
Yes.
Yes. We are both from the same genre because both of us have been inspired by him. We came to this field through him. I remember him also because he died of COVID last July, and this was very shocking for us also to get over it. The oncology, of course, has widened a lot, and as we know, it has got so many angles and spheres now. It's a huge family. There's a huge classification of oncology. So it's expanding day by day. And in the field of radiation oncology, as a radiation oncologist, I also feel that we are doing tremendous progress, especially with computerization going on. But with the advent of COVID, what happened in my hospital was an eye-opener. Till March, everything was fine. Then suddenly a lockdown came. And then people got a bit scared, but still people were working. And suddenly one COVID case appeared in a hospital. As soon as that happened, hell broke loose. Absolutely hell broke loose. All the staff and other members, they just stopped coming. They stopped interacting. There was a lot of chaos in the wards, a lot of animosity towards management. And our poor director, had a very tough time managing everything. But slowly, within a month's time, we again got back to our toes and started giving service. Of course, the patient number became 1/3, and slowly again we picked up gradually, and with time we have picked up a lot. But still, the spirit is not the same because there's always a kind of a fear all around. That's something that happened to you. It happened to me also. I got COVID last November, and I was very sick. I was in ICU for 9 days. So it can happen to anyone. So of course the patients are more at fear because on one hand is a COVID fear, on the other hand is a cancer fear. So we feel for them, and we try to be as sympathetic as possible. But sometimes there are limitations also on our part. Anyway, I think this discussion will help all of us to come close to what the situation is like, especially in different specialties like radiation oncology, like oncology, like surgical oncology, and then the other field also. So let us hear from the speakers and get more information, interaction, and get us more prepared for this. Thank you. Please continue.
Rakesh, please take over.
Yeah. So thank you both the chairpersons for that wonderful introduction. Am I audible first of all?
Yes, you're audible.
Yeah, good evening and a very warm welcome to all the participants. It includes not only our respected seniors, but also our dear colleagues and dearest juniors. It is indeed an honor and privilege to be a part of this wonderful forum. And for this, I would like to thank Dr. Roy Choudhury, Dr. Ghosh, and Dr. Shen Sharma. We are here today to discuss a very, very important issue and a very burning topic, that is how to manage cancer patients. Yeah, so how to manage cancer patients during this pandemic, because we know that cancer will not wait. Now, ever since this pandemic stepped in, we have been actually experiencing a lot of uncertainties and a lot of problems. We have seen that we have not been able to comply with the international guidelines that was given to us to maintain the standard of care. And this was mainly because there was an ununiform distribution of resources, infrastructure, policies, and services across the state, and also to an extent across the nation.
ও
So we
বলো
have
স্যার
had
দেখা হয়নি
problems.
কালকে তোমাদের 12টার সময়।
So I think Demalo is unmuted. Yeah. So we have been experiencing these kind of problems in the last 1.5 years, and we really don't know what is the best way to actually manage cancer patients. So today what we have is, we have a very august and erudite panel team who are going to discuss the practical aspects of managing cancer patients during the COVID-19 pandemic. So can we have the slide deck, please? Someone please share the slide. Yes. Yeah, can you just skip this slide? Yeah. So we move on to the list of panel members, and I would like to request all of you to acknowledge once I read out the names. I would start with the senior most person, Dr. Gautam Vishwas. Sir,
Yes.
are you there?
Yeah, I'm very much here. I hope you
Yeah,
can
sir,
see.
actually, yeah, thank you, sir, for being there. Sir is actually a reconstructive surgeon. He's a consultant at Tata Medical Center, Kolkata, and sir represents Medicos 1974. Then we move on to Professor Saurabh Ghosh, who was nicknamed Laduda by we juniors when he was there in college. Sir is the head of the Department of Surgical Oncology, Medical College, Kolkata, and sir actually represents Medicos 1989.
Good evening, everyone.
And then I move on to my dear friend, I move on to my dear friend, Dr. Rajkumar Shimali. He's my batchmate representing Medicos 1992. Raj is a consultant clinical oncologist attached to Arden Cancer Center, Coventry. And the advantage of having Raj here is Raj also worked as a clinical consultant in radiation oncology in Tata Medical Center for a decent period of years. So it will be very wise enough to have him in the panel, because he'll be able to share his insights and inputs on how he managed patients here and how he has been managing patients in the UK. The final two panel members are the young and very enthusiastic and energetic group of people. Both are Bhattacharya. Both are representing NRS Medicos 2002, and both are attached to Apollo. Dr. Devmalu Bhattacharya is a consultant hemato-oncologist and a bone marrow transplant specialist. And Dr. Jivok Bhattacharya is a consultant radiation oncologist. So do we have both of them there?
Yes, yes.
Jivok,
Thank
can
you, Rakesh,
hear
for your very nice
acknowledgement
introduction.
Good evening,
Yeah.
everybody. I'm
So
Jivok.
Jivok, are you there?
Yes, yes.
Yeah.
Fine. And myself, Dr. Rakesh, I'm working as a medical oncologist in Saroj Gupta Cancer Center, Kolkata, which was formerly the Thakurpuku Cancer Center. Can we have the next slide, please?
Yes, sir. This is the next slide.
Yeah, so it will take a bit of time in my device because the lag time is there. So I've not been able to see the next slide.
Okay.
Yeah, now it's okay. Now it's okay. Now it's fine. Yeah. So before we start rolling the slides and before we discuss the clinical cases, let me take a one-liner perspective from all the panel members. I'll start with Professor Saurabh Ghosh. Saurabh, your perspective, pre-COVID times versus COVID times, a couple of sentences, please.
Obviously, there are a few changes. We need to identify the COVID patient, both for his or her own safety, as well as for the safety of the people delivering healthcare to him or her. If he is not COVID, we need to ensure that during the process of getting treatment in the hospital, which is also accommodating COVID patients, we don't transmit, or we minimize the risk of transmitting COVID to him. So as it is, oncology may be a challenging scenario in the government setup. This makes it more challenging.
Right. We move on to Dr. Gautam Vishwas. Sir, your inputs and insights.
Good evening. What has made COVID more of a problem is because of the uncertainty. We really did not know what exactly this disease was. And there was and the whole system got upset because the COVID infection, as has been just said, could be transmitted within the community and outside the community. That means within the medical community and outside. So
Correct.
this created a lot of problems initially, but I think now we have streamlined and started following certain protocols which are more into conforming to standards. Okay.
Okay, we move on to Dr. Raj Kumar Shrimali. Raj, I think the setup there is partly different, and I'm sure the ideology and the attitude of people in the West is different. So your inputs, your perspective, pre-COVID versus COVID.
I think there are some differences and there are a lot of similarities. So the number of cancer diagnoses have gone down in the last year and a half because a lot of the diagnostic procedures have been aerosol generating procedures. So there was, for a little while, all of the endoscopies were suspended unless, except for the life-threatening conditions where somebody was having an active bleed. All of the bronchoscopies were suspended again for the same reason for some time. When it came to lung function tests, the TLCOs, gas transfers were suspended. Prostate biopsies were suspended for quite some time. So there was a problem with the diagnostic pathway. In February, in sort of end of February, we were hearing about COVID. By the end of March, we went into lockdown, and that was when I caught COVID and I was ill. I was off for a month, but I've been getting emails and I know that all the specialties were dissolved and everybody was put onto the front line for COVID management. And we had oncology consultants working in the casualty department doing 8-hour, 12-hour shifts. So that was the kind of situation. It was a bit like the army. When you're fighting a war, even the cooks in the army have to fire guns. So it was a bit like that. It took a couple of months to get on top of things. And then since then, it has been a very slow path of recovery. We have had to take into consideration a lot of things. So a lot of the adjuvant treatments have taken a backseat. So yes, a lot of changes really. Thank you.
Should I share, sir?
Sorry, have you lost me?
Raj, you are very much audible.
Yeah. So yeah, I mean, I've said what I had to say. That there were a lot of changes. The whole system was upside down for a month or two, and it has been a slow recovery.
Yeah. Can we move on to Dr. Demallo?
Yeah. So in our perspective, same thing. We suffered a lot due to the COVID pandemic. Our situation and our work style has been all drastically changed. Even now, I can feel. Yesterday only I was discussing that just a few years back, our practice was different from center to center, from clinic to clinic. We are moving. Right now, we cannot do such like that. And also, obviously, many of our treatment strategy, chemotherapy strategy has been changed or has been forced to change because of the COVID situation.
Someone has unmuted the microphone. Yeah. Okay. Demallo, you can continue, please.
Hello. Am I audible now? Yeah. So COVID has changed our practice also a lot, not only the patient's number or everything, but our day-to-day activities have been changed. Before COVID, we are used to do from this hospital to this hospital. We are giving consultations very frequently and easily, but COVID has restricted our activities, our movements, so we are now restricted to only few centers. So, and also there are many challenges which have faced during this first 1.5 year. So I think everybody will be same have same experience with me, like me. So that's it.
অভিজিৎ মিউট করতে বল, অভিজিৎ, জয় মিউট করতে বল, মিউট।
ছাড়া বাকি সবাই মিউট করলে ভালো হয়।
মিউট করে দে দাদা।
I am requesting all the participants to kindly mute please, only the speaker, the moderator, and the panel.
So I think Jivok will have the same experience. So I will request Jivok to share his experience.
So, so it was as Dr. Bisha said. So initially, it was too much uncertainty, and we did not know what to do exactly with the situation. And once it started to break out in the oncology building, basically in oncology patients, they were getting affected one by one, and we we did not know what to do exactly at that time. We had to rearrange our staff management at the same time with the patient management also, because the doctors, junior doctors duty, then the radiotherapy technologies duty, because they are getting exposed to all those patients initially. Then after lockdown, the number of patients decreased, and with time we got accustomed to the situation, and we started to think about the solutions to basically continue the treatment. And now I think initial 2-3 months, maybe up to 3-4 months was very difficult to tackle the situation, because it was a sudden change in the situation. But now we are used to it, and situation is changed. We are getting patients, and also what Dr. Srimali said, that due to the diagnostic delay in the procedure, we are getting a lot of locally advanced cases, mainly the head neck cancer cases, which could have been diagnosed earlier. Probably they are coming with locally advanced stage, and many of the follow-up patients did not visit during the lockdown period, and they are coming late, basically.
Thank you, Jibok, and thank you all the panel members. That was quite elaborative, in fact. So I would request the organizers to stop sharing the screen so that I can share the screen, because I fixed the problem in my laptop, and that will make things easier for me. So I'm just trying to share the screen. Chairpersons, please kindly acknowledge if you see my slides. Let me know if they're visible.
Not yet, sir.
Not yet.
Okay.
Yes, sir. Now it's visible.
Yes, now it is come.
Okay. So, and I'm going to roll my slides. Get to see the rolling, then let me know. So I've just moved on to the guidelines slide. Is it there? Is it visible?
Yes, it
okay.
is there.
Yeah, so we just talked about the uncertainty, and Dr. Bishash rightly said that COVID is so unpredictable and so uncertain that we really cannot set standards against this. It's highly a very fluidic or a very volatile situation where guidelines are being flouted, violated every now and then, they are being changed, and then the very next year new guideline is coming up. So keeping this context in the background, we will try to discuss some very important issues as to how practically we can manage cancer patients during this pandemic. So I'll show you very slide, and the slide is important in the sense people should know what is the case specific fatality rate for patients suffering from cancer in the same contracting COVID. So the most comprehensive data that comes from what was a joint contribution of WHO along with the Chinese Commission on Coronavirus They collected data till February 2020. Remember, this virus was discovered in China in 2019 December. So within 3 months' time, they decided to publish a data from the China, and they wanted to show what is the incidence of the case fatality of cancer patients if they contacted COVID in the same time. And they found that it was 7.6%. And they found that the case fatality rate in the overall COVID population was 3.8%, exactly half that of the cancer patients. And in case the patients did not have any underlying comorbidities, the rate came down to 1.4%. So it's very clear. In normal population suffering from COVID, the total percentage was 3.8, but the fatality just doubled up if the patients had an underlying cancer. Actually showed that like patients with COPD, hypertension, diabetes, and ischemic heart disease, patients with cancer who are contracting COVID have a very high risk of fatality. So this is a very important message that we got from the Chinese people. And so move on to the first case. Am I still audible?
Yes.
Audible.
Okay, thank you. So this is the first case, and I will start off with Professor Saurabh Ghosh, who is the head of Department of Surgical Oncology Medical College, a government establishment, and I'm sure he has faced a lot of challenges in managing people, managing politicians, managing resources during this COVID pandemic, and it's an ongoing process. This is a 58-year-old male who had a history of diabetes and hypertension, but controlled with drugs, who presented to the emergency with abdominal pain, distension, vomiting, and altered bowel habit. So the patient presented in the ER of Medical College. Immediately, a straight X-ray of abdomen was done, and this is the finding. So how would you proceed in the ongoing COVID search? Professor Saurabh Ghosh, your opinion, please.
In this particular case, there are two aspects to be seen. One is the management of the acute problem that the patient has come with to an emergency, abdominal pain and vomiting. And secondly is to find out whether the patient has got COVID or not. And if the patient has COVID, how it's likely to impact his treatment. So for all patients who are attending hospital during this time in the emergency, we are having certain basic procedures in step for trying to identify whether they are COVID, whether they have a history of exposure to COVID patients, whether it's a small checklist that you can go over very rapidly, whether they are having any febrile illness for the last 5-7 days or not, cough, loss of taste, generalized body ache and weakness. If they have had, if they may be a known COVID patient, sometimes a known COVID patient may come with another problem, then a rapid thermal screening can be done. And if these things are all negative, then at least there is nothing to go on that the patient is a known COVID. So in that case, the patient becomes a COVID unknown. So this is the bare minimum that we would like to do in a government setup to find out whether the patient has COVID or not then and there in the history and examination part. The particular patient that you have presented has got classical features of acute intestinal obstruction, that is abdominal pain, distension and vomiting. But the straight X-ray abdomen shows a large tire-like distension, a gaseous distension, which is showing a haustral pattern. So this is a colonic obstruction. So this is an acute on chronic obstruction. And from the distension, this appears to be at least a sigmoid. The distension is going right up to the sigmoid. So the obstruction, I think, would be lower down. So I have not seen the patient, but I would do a good general examination and I would do a per rectal examination. And probably there is some cause in the rectum. There is some cause in the rectum. Obviously, I would have to take a relevant history about a rectal malignancy, whether there was any bleeding, whether there was any alternation of bowel habit, whether there was any spurious diarrhea, whether there was a sense of incomplete evacuation of stool, or there could be some other possibilities also which you have to keep in mind. Maybe the patient has got chronic constipation. There's a condition known as a pseudo-obstruction, Ogilvy's. So we need to see all this. And we need to do a per rectal examination. So almost 70% of rectal cancers, are palpable on a good digital rectal examination. So if we do find a rectal growth, I presume that you want to take the discussion along the line of a rectal cancer. So if you do find a rectal growth there, then obviously our diagnosis is made more or less. We still need to confirm it by taking a punch biopsy. Sometimes the patient may already be a known patient of CA rectum, but because of the COVID times, he or she may not have presented to the ER because of the problems in transport and things like that. And the patient may have a pre-existing biopsy. Patient may have been advised surgery in the private sector but could not afford it, and did not know enough to go to a government setup. Very often we find the patient saying that I could not afford treatment. And when we ask them that you could have come to a government hospital, the treatment is free. Then they say, we were not aware that the treatment is done in a government hospital. We were not sure where to go. So these are problems which we face in a significant percentage of our population who are uneducated, who are not aware of the facilities that are available. Anyway, be that as it may, now the patient, if he or she has a diagnosis of a rectal cancer.
Saurabh, I would like to stop you here. I'd like to stop you here. I have a couple of questions. So let's presume that this patient had a rectal cancer, suspected rectal cancer. Let's presume that this patient did not undergo any histopathological tests in the past. So this is a diagnostic naive and a treatment naive patient who has come to your ER. Now, we read in the newspaper about a year back, about 3,000 beds were being dedicated to COVID care. And a lot of people who were working in a hospital, including the staff, were siphoned to the COVID ward. Now, do you still ensure that there are adequate number of beds currently in the hospital to accommodate these kind of patients? Because I think it deserves an admission.
No, if you ask me an honest question, then I will have to say that the number of beds required to cater to a population of the entire Kolkata and its suburb, the poor population, I presume, the rich people probably can go to a private sector, the hospital. It is not enough. And many of you must be aware that among the government hospitals, especially in 2020, when COVID first appeared in Kolkata and the cases started rising, Medical College Kolkata was converted to a COVID hospital almost overnight, along with CNCI and also the place near Barakpur, Sagar Datta. These were the three institutes which were the government, along with ID Hospital also, ID Hospital Belegata, Medical College Kolkata, Sagar Datta and CNCI. Overnight, we were catering to the hundreds of COVID cases which were coming up. And there were not sufficient number of beds, there were not sufficient number of other equipments. So drastically, the normal functioning of the hospital had to be reduced. But you're right, this patient deserves an admission. But in many cases, we cannot be able to do it.
I will simplify things. Let's presume that this patient had a political catch, and some way or the other, the patient has managed to receive, get admitted to one of the beds. Now, I just want to know from you, suppose this patient came to the ER around 9 o'clock in the evening. Do you do a COVID test right at that point of time, or you put the patient in an isolation ward and do the COVID test in the next day?
The swab collection will not take place on an emergency basis at 9 at night. So the swab will have to be taken the next day. What would be done in that case was to make a COVID unknown ward, a COVID status unknown ward, and the patient would be kept there. Anyway, in an emergency setting, the patient needs to be resuscitated first. Certain baseline treatment need to be started, which can be done. So we would do that, and we would take the swab next day.
Yeah, fine. So to simplify things, because we have a lot of audience and a lot of participants here who probably do not understand the fix of oncology. Just to simplify things, this is a diagnosis naive patient. The patient has not received any treatment, who presents to the medical college emergency 9 p.m. at night. The patient is COVID status unknown. Patient is put in an isolation ward where all the unknown status patients are put, and the patient needs some kind of resuscitation, and the resuscitation. The very next day, the patient started feeling better. The very next day, a swab was taken, and within hours and Dr. Ghosh comes for a round along with his residents and finds that the patient is quite fit. He doesn't have too many comorbidities, is manageable patient, and he plans to do some kind of an intervention. So Saurabh, the report is COVID negative. Now, what are the investigations you want to do? The patient has come only with a straight X-ray abdomen.
Right. So if the patient, as you said, has improved with the initial resuscitation with IV fluids, with a nasogastric tube, with the fluids, correction of dehydration and electrolytes, we've got a perurethral catheter in situ, and we find that the urine output is adequate, the dehydration is corrected, the vitals are stable, and on examination, we find that there are no features of acute abdomen, there are no features of peritonitis or sepsis. Then the minimum investigation that I would like for this patient would be a punch biopsy from the rectal growth, if I can feel it. If I cannot feel it, I will have to ask for a proctoscopic or a colonoscopic, sigmoidoscopic biopsy. I would also like ask for a contrast enhanced CT scan of the thorax and abdomen. Since the COVID patient is COVID negative now, the patient can be taken to the CT scan suite. And I would also ask for a serum CA along with baseline blood investigations and routine investigations like X-ray, chest X-ray, ECG, routine blood investigations. I'm not going into that. I'm sure you all know.
Perfect. Perfect. So, Saurabh, the practice in medical college that you don't insert a colonoscope without getting a COVID report?
Yes. Nowadays, they would insist on getting a COVID report before doing a colonoscopy, any sort of endoscopic procedure, whether it is bronchoscopy, whether it is upper GI endoscopy, whether it is colonoscopy, or even whether it is this cystoscopy.
So this is one patient you have in the ward. The COVID report is negative. Patient has been transferred to a safer ward. And there's another patient who also has a political catch, a lady with a breast cancer who can go for an elective surgery because it's not a large tumor. It's, let's say, a tumor. So do you prioritize your surgeries? Do you give more preference to this patient rather than that patient?
Certainly, we would prioritize on the basis of two things. One is if it's a dire emergency where it is life-threatening, we need to do something. So you have simplified matters by saying that the patient is a COVID negative. What if the patient was a COVID positive? Even then, an emergency is an emergency. But you have to counsel the patient. We have got data that suggests that elective surgeries in the COVID setting increases the perioperative mortality to the tune of 20%. So that is a significant risk. But since it is an emergency, the patient and the relatives have to be counseled about the possibility of increased perioperative mortality risk. And nevertheless, we have to go ahead. The principle should be to do minimum. So in this case, if it was not responding to the conservative management, the patient was getting dehydrated, there were features of sepsis, there were features of peritonitis, and I had to do some sort of surgical intervention to relieve the patient, I would go in with a small laparotomy and come out doing a transverse colostomy or a sigmoid. If I felt that the definitive procedure would be an abdominoperineal resection, then maybe I would do a sigmoid colostomy. If I felt that I was not certain what the procedure would be, I would play safe and do a transverse colostomy. That would not be a very extensive surgery, but it would effectively relieve the patient of obstruction, and it would buy me some time where I can stage the patient properly. The patient can get over the COVID situation, and then I can, if necessary, some neoadjuvant therapy can be given. The obstruction, if I have the facility, I would consider a non-operative removal, relief of the obstruction by certain sort of endoscopic stenting, but that is not always possible in the government setup. But for theoretical discussion, self-expanding metal stent may be used to relieve the obstruction if the facility is there. A non-operative method for relieving the emergency is always better than an operative method in a COVID positive patient. In a COVID negative patient, these are much simpler issues. You don't have to worry so much. So we can consider definitely prioritize.
Yeah. So what is the practice after you perform a surgery? Do you put this patient in the ICU for a couple of days?
No.
Is that the practice?
No. Staying in ICU would be dependent on the other conditions. So the indications would be if there was a lot of hemodynamic instability, or if it was a supramajor surgery which continued for say 7 or 8 hours, or the patient is having some sort of post-op delayed recovery or inadequate recovery. These would be some hypothermia. These would be the indication of keeping the patient in ICU post-op. A routine colonic or a rectal surgery, the patient does not go to the CCU.
Okay. Now, suppose we have a case where you are planning to do a surgery because the patient needs it, but you are not getting the date for the surgery. The OT is probably booked, or maybe you don't have a very effective anesthetic team at this moment because they're all indisposed because of COVID or so for some other reason.
The emergency setting you're talking, or elective?
No, I'm talking about elective settings, not emergency. Emergency, it's very clear. Yeah, so in elective settings, suppose you have a chance of operating a patient, but due to some reason or the other, your resources are not there, and you will get back to the resources after a couple of weeks. Do you bridge the gap by giving some form of systemic therapy just to buy some time for these patients, because you think that if you waste too much of time, these patients can be upstaged from a stage 2 to a stage 3, something like this, new adjuvant CT?
Yes, of course. Even you know, Rakesh, that even a stage 2 rectal cancer would probably mandate a neoadjuvant therapy anyway. If there was an emergency like an obstruction, we would have to go in for surgery. But since you have said that the patient is stable and I am not getting a OT slot anytime near, so even stage 2 is pretty broad. Say, let me say it is a T3N0, early T3N0, where maybe if I do or even a slightly advanced T2N0, where doing an upfront surgery may not be a big crime. I am seeing on my staging CT scan or on my
Right.
MR of the pelvis, if I have got it, that the CRM is not threatened. The circumferential resection margin is not threatened. I could go ahead with the surgery, but since my logistics are not allowing me, I will definitely refer it to the radiation oncology colleague, because they may be in a better position to give a date for neoadjuvant radiation and buy me the time. Absolutely.
Okay. Yeah, thank you for your inputs. We move on to Dr. Jeepak Bhattacharya, who's a consultant radiation oncologist practicing in Apollo. Jeepak, we know that locally advanced rectal cancers, one of the standard treatments would be neoadjuvant chemotherapy combined with radiation at the same time. So my opinion from you is the one thing I would like to know, there are different ways of giving radiation. There is a short course, there is a long course. Now, how have you customized approach in practice in COVID times? Are you preferring the short course or are you preferring still the long course?
Okay, so the long course radiation that is for over 5.5 weeks, that is 28 fraction, that is considered to be the standard till date, and that was practiced for last few years. So our current practice is still the long course radiation. However, the upcoming data is showing the five fraction radiation, which is which takes only 1 week. That is the 25 fraction, which is coming up with good results, almost equivalent results, and after which you need to go for the surgery, and that saves a lot of time, and that is also helpful in this situation. But we in our center, some of the patients, due to their logistics, they took short course radiation after offering such a kind of fractionation exists. But routinely, whatever patients we have seen in last 1.5 years, mostly they receive the standard fractionation. The short course radiation, the number of patients receiving short course radiation is very low. Basically, it's mostly the standard fractionation.
Right. For the audience, just to simplify things, Jeepak, 28 fractions means one fraction per day for 28 days.
And that is also weekendless. So that means it will be total around 5.5 weeks. So 1 week is equal to five fractions.
That's
so
right.
5 weeks equal to 25, and 3 more days. So total 28 days. Total 28 fraction means almost 5.5 weeks.
Yeah, so it's almost 6 weeks. Now,
yes.
Suppose you are a person who's not staying in the city of Kolkata. The person actually comes from the suburbs. And during COVID times, it was actually very difficult to get a room, to get a bed in some informal place. Now, so therefore, it is not going to be easy for a person to come every day from his establishment to your center for a radiation. So, Dr. Saurabh Ghosh, coming back to you, you're happy with the short course radiotherapy along with oral capecitabine?
Yes, my absolute indication for a long course chemoradiation would be threatened CRM. If the CRM is not threatened, I think I can get away with an R0 resection. Then the purpose of the neoadjuvant radiation is mainly to reduce pelvic recurrence. I would be absolutely fine with the short course radiation in this.
So, can you just elaborate what is CRM and what do you mean by a R0 resection?
CRM stands for circumferential resection margin, which is the most critical margin in the pelvis, because the pelvis is a closed structure. There is not enough space to go either way. And so the proximally or distally in the rectum, we've generally got margins. For a long time and surgically, we used to debate about the distal margin. What is adequate? 5 centimeters, 2 centimeters, 1 centimeter for well-differentiated tumor. But we didn't talk about CRM until for the last 10, 12, 15 years maybe. So CRM is the most critical issue, the circumferential resection margin, where you don't have much space. So the rectum, any tumor grows three-dimensionally, not just proximally and distally along the lumen. It also goes transluminally into the surrounding mesorectal fat, and then beyond that into the pelvic soft tissue. So if those tissues are involved, then while we are circumferentially resecting it, our margin will become positive. That is where the concept of R status comes in. The R status of resection is R0, R1 and R2. R0 is where there is complete tumor removal at the end of the operation. R1 is where all the gross tumor has been removed, but microscopically your margins may be involved by the tumor, which you cannot see. And R2 is where you have grossly left behind visible tumor in the body after your resection. So the aim is always to get a R0 resection.
Thank you, Dr. Ghosh. So this is what the practice has been. We have customized our approach. instead of giving those 20 fractions of radiotherapy, at times we are actually giving lesser number of radiations, and that we are combining with an oral chemotherapy. Before we used to give injectable chemotherapy, but we have come to know that a 5-FU infusion is as good enough as an oral capecitabine, and you don't compromise on the efficacy. Yet it's much easy for the patients to pop pills rather than take IV infusions of 5-fluorouracil. So this is one of the changes we have made. Now I move on to Dr. Devmallo Bhattacharya. Devmallo, can you hear me? Devmallo, can you hear me?
Hello.
Yeah,
Hello.
Devmallo.
হ্যাঁ শুনতে পাচ্ছি বলো।
Yeah, right. So Devmallo, my question to you is, a patient wants to undergo an intervention and the hemoglobin level of the patient is 7.9 and the patient has, let's say, B negative blood group. So what are the indications of blood?
Yeah. Actually, indication is that when there is hemoglobin is less than 8, any emergency operation or whatever elective operations, the rapid way to increase the hemoglobin is giving a blood. So for this patient where the status is not known whether there is any internal bleeding or not, better to transfuse 2 units of blood. But in COVID scenario, that will be challenging because many of the blood donation camps or political programs have already been cancelled. Many volunteer donors who are not who are previously used to donate blood on frequent basis, especially negative group blood. Hello, am I audible?
Yes.
Yes. So these are the issues that we have faced in last 1.5 year, that if person wants to donate blood but he cannot come because of the could not come because of the lockdown. Scenario 1. Scenario 2, that there are some specific donors or selected donors for particular blood banks, especially those who are having negative blood groups like B negative, AB negative or O negative, which are rarer blood groups. So for those patients, for those requirements, we often call those patients, those donors that you please come and voluntarily donate this blood, donate your blood for a particular patient. For this COVID time, these voluntary donors also, they refuse to come because of the fear that if they go to hospital they will catch COVID. So that is a genuine fear on their part. But these are the issues we faced during the blood transfusion issues. So especially blood bank people, they are very much ravaged with this problem, that there is a lack of donation in this COVID time.
So Devmallo, the main question, patient needs will not be able to give blood. So can you give something else as a substitute for the time being? I do understand a packed vessel transfusion cannot be substituted by anything, but is there anything, something else you can do?
No, this is very difficult because if there is any planned surgery within 1 to 2 days or even 1 week, there is no shortcut to increase the hemoglobin other than blood transfusion.
Perfect. We move on to Professor Shorabda. Shorabda, you're happy to operate a patient with a hemoglobin level of 7.9?
Did you say 7.9?
Yes.
Yes, I'm perfectly happy to operate on an emergency or a semi-emergency patient with a hemoglobin of 7.9. We have enough data to suggest that a hemoglobin above 7 is okay for post-operative wound healing.
Perfect. I will go to Dr. Raj Kumar Shrimali. Raj, sorry keeping you for such a long time. Raj, is there any prioritization of surgical cases in the NHS? Are there any cases which get more priority over some of the other cases? So perfectly, I mean, this is probably one of the best examples. Raj, your inputs?
Yes, life-threatening cases get the top priority, and cancer patients get higher priority than non-malignant patients. So planned orthopedics go to the bottom. Planned orthopedic surgeries like joint replacements and things. Cataract surgeries will go down. So yeah, I think life-threatening cases and sort of more advanced cancer patients will get the highest priority.
Yeah, so I think the practice is a bit similar. I mean, whichever part of the globe you go, we know that UK was badly hit by COVID. We were even more badly hit by COVID, but actually the wave came a little later once. And
I
So
can't
this
hear
was
you.
You're not audible.
Not audible. Sound is not coming.
Rakesh, you are not audible.
We can't hear you, Rakesh.
I think anyone else, please take over. Please take over, anyone else.
Who has the slides? If anybody has the slides, can move the slides.
Rakesh, log in again from the phone. You know that.
Rahul, why don't you take over? You have the slides.
I don't have the slides actually.
Shogata has the slides.
Shogata has the slides, but having said that, we can move the discussion along. Yes. Rakesh, are you there?
I think he is disconnected and will connect again.
He's logging back in.
Yes.
So, Dr. Srimali can actually continue with the discussion for the moment, and Saurabh, just to complete the discussion.
I think I answered the question. Yes, the operations have to be prioritized, and like anywhere else in the world, the life-threatening surgeries take top priority. The surgery for life-threatening conditions, I mean.
But your specialty is actually medical oncology, is it not?
It is clinical oncology. So I do radiation
oncology.
and systemic therapy.
So just ask you about this, because I know clinical oncology forms an important part of NHS. And what are you doing in terms of radiation in a case that Saurabh was discussing? Would you actually go for the short course or the long course? On the same patient that Saurabh was discussing.
Devmalu, just mute yourself, please. Rahul, I am back.
Okay, thank you.
Yeah.
Yeah. So in patients who had CRM threatened, they were going for a neoadjuvant treatment, and the neoadjuvant treatment, the primary aim, as we all know, is to try and downstage and to reduce the risk of local recurrence after surgery. But one of the aims in the times of COVID was also to keep these patients out of hospital as much as possible. So the systemic therapy was often curtailed, and the radiotherapy was often more hypofractionated. So at the peak of the pandemic, this patient would have received a short course radiotherapy alone, but we would then delay the surgery by 6 weeks. And there have been studies that have shown that even with five treatments or 1 week of treatment, because each fraction size is higher, if you leave it for a number of weeks, in many of these cases will get downstaged. And it is I mean, there is a fine balance between risk and benefit. So yes, we want to downstage the cancer, but at the same time, we want to keep these patients out of hospital and not increase the risk of catching COVID.
Yeah, Raj, this is Rakesh back again. Sorry, I got disconnected. Can you hear me?
Yes.
Yeah, so Raj, there are some people who probably would not understand what hypofractionation is. Can you just clarify what you mean by hypofractionation?
So hypofractionation is a word that is used to describe the regime for delivering radiotherapy. So standard in standard fractions, we deliver 1.8 to 2 gray per day. So it is a single treatment every day, 5 days a week for a number of weeks. So in this case, depending on whether you follow British or American guidelines, you would be using either 25 treatments over 5 weeks or 28 treatments over 5.5 weeks. And each of these treatments is 1 treatment a day for 1.8 to 2 gray. When we do hypofractionation, what we do is we use 25 gray in 5 fractions over a week. So it is 5 treatments, but each of those treatments is 5 gray. So although the overall dose is slightly less, that it is a higher dose in a single sitting each day, which reduces the repair in the tissues and is biologically not very far off from standard fractionation. So the standard fractionation where 45 to 50 gray is used, with hypofractionation we are still giving around 42 gray. So it although 25 looks very small, but because each fraction size is higher, the
Right.
biological comparison, we are actually giving 42 gray.
Right. So this is one of the techniques I thought everyone should understand, that since you are trying to reduce the time span of giving radiation therapy to the patients, because you need to do it quite fast, because logistics will probably not allow you to hang around near the institute at come 5 weeks at a stretch. You do this practice of hypofractionation, you give less number of shots, but every time you give a shot, you end up giving a higher intensity. Perfect, Raj.
And it has multiple knock-on effects.
Right.
Because not only does the patient visit the hospital fewer number of times, if we do that to a large number of patients, we are also reducing the duration of the machine on time, because between patients we have to factor in time for cleaning up.
Right, perfect. So we move on to
we
move on to the next case, case capsule 2. And for this, I would be seeking opinion from Dr. Gautam Biswas. Is the case capsule 2 visible, Rahulda?
It is visible. Thank you.
Okay, yeah. So a 39-year-old male patient reported to the Department of Oral Medicine with the chief complaint of an ulcer in the tongue for the past 6 months. He had a history of addiction. He was a chronic smoker and a punch chewer for the last 10 years. On examination, he was found to be having an ulcer proliferative growth, which was seen in the left side of the anterior 2/3 of the tongue, but it was also extending to an extent into the ventral surface. The dimensions are 4.5 into 2 centimeter. The margins are reverted. On palpation, the tumor bled on touch and it was soft in consistency. The base was not indurated. On examination, it was found that the patient was having a couple of lymph nodes which were palpable clinically on the left-hand side. So, Dr. Biswas, if this kind of patient comes to your clinic during the COVID pandemic surge, how are you and your team going to manage this patient?
First, let me clarify. I am a reconstructive surgeon in head and neck.
Yes, yeah.
Most of my work is head and neck cancer, amongst sarcoma, etc. Anyway, so to come to the patient, first of all, patients attending our hospital, which is tertiary care hospitals, often come late. And with COVID, things have been compounded. So whether they are coming in late or reporting late is very difficult to assess. But since the history is 6 months, I presume that this patient has been seen earlier by other physicians. Anyway, the reason for not coming, of course, is logistics. That is what they're... Now the problem is, I'll walk you through these patients when they come to our center. Number one is these patients are primarily screened whether they have some history of travel or smoking, fever or body ache before they are taken in to the outpatient department for whatever treatment or whatever examination required. So we access the patient only when they are asymptomatic. I'm talking in terms of COVID. Okay. So now the patient comes into our OPD. The biggest problem in this is these are all, we are working in the oral cavity, which is an aerosol generating area. So the risk is to the medical fraternity is quite high. So we were using conventional N95 masks and visors. Whether that is adequate, very difficult to say, because we've had people getting infected even in the outpatient department. So the question comes, we'll need to take a biopsy for this patient after, of course, a thorough clinical examination. And taking an intraoral biopsy at that point of time with an unknown COVID status has its disadvantages. But of course, for simple biopsies, we were not subjecting these patients to any COVID tests or to confirm whether they are COVID or not. So we would take a biopsy, and then, of course, we would assess them and plan them for surgery. Now, now when the patient has been investigated, other than the general surgical investigations that are done for any surgical procedure, I think an MRI and a CT chest and neck is what we usually perform, because this is tongue, we do an MRI, otherwise just CT chest and face. And we would like to assess whether what is the margin from the lesion to the mandible. If they are close, then the patient might require a marginal mandibulectomy or even sometimes a segmental mandibulectomy. So depending on the type of lesion and its proximity to the mandible, we would decide what the excision is going to be. So this patient is then planned for surgery. You want to ask me something, or do I move on?
Yeah, so I just wanted to take your special opinion regarding how do you place a PET CT scan? Because a lot of people undergo PET CT scan, whether you recommend it or not, and they probably come with the package in their hands. So do you think a PET CT scan has any kind of role in these kind of patients?
No, I don't think so, unless there is obvious metastatic disease. PET CT scan would be indicated to see if there is obvious metastatic disease. But usually these tongue malignancies would first travel onto the cervical nodes.
Right.
So, and a CT chest is sufficient to detect the next level of nodes metastasis. If there are multiple metastatic areas, then only a PET CT is required, which is very rare in this sort of situations.
Right, sir. So you have done a histopathological examination. The report comes out to be a confirmed case of squamous cell carcinoma. But in this meantime, when you were actually preparing the patient for some kind of an elective surgery, the patient's RT-PCR test comes out to be positive. How do you place yourself now?
So the patient is given a scheduled date for surgery.
Right.
That usually a histopathology would take about 2 weeks. Now you say within that 2 weeks, the report comes as RT-PCR positive. This usually, I presume that the patient is now being taken into OT. So 372 hours prior to that, we need a RT-PCR positive test.
Correct, correct.
So a patient wouldn't have done it otherwise. So let's presume that we have done the test and now the patient comes out to be positive. So the guideline that we were following was that we would give them, postpone the date for another 2 weeks and then repeat an RT-PCR test. So, but the present, we have evolved from that, and now presently, if the RT-PCR comes as positive, we would wait a period of 17 days and then carry on with the surgery. So I think there is enough documents to say that you might carry on getting RT-PCR positive, which are shreds of the RNA vaccine, RNA that is there, but usually they are not infective. Of course, I'm talking about patients who are asymptomatic. If they are symptomatic, we carry on postponing surgery.
Correct. So understood, sir. And suppose this patient didn't have a COVID infection and this patient was being taken up for a planned surgery. Are you vaccinating this patient 7 days prior to surgery? Is there any such protocol in your institute?
I don't think vaccination, we have started vaccination. All our patients who are, obviously that's a voluntary program, that means patients do get vaccinated.
Okay.
Of course, there are patients who refuse to get vaccinated.
Right.
So we have all different, but that will not influence the treatment care. So whether they are vaccinated or not, that is just a point that is there, a footnote on our case sheets, but that will not in any way change the protocol of management in these patients, even the schedule.
Okay, sir, will this patient require a reconstruction?
Yeah. So let me come to that. Now, there are two things that you raised. Number one was that the patient was COVID negative or COVID positive. So the relevance of that is whether 2 weeks would make too much of a difference. If we are postponing surgery and we presume he's asymptomatic, and 2 weeks is the delay that is going to offer. Very difficult. It is very difficult to have a data to say 2 weeks delay would cause any problem or not. Obviously, longer delays you can have upstage, but usually patients attending our setup are usually in a advanced state of disease anyway.
Right.
So looking at this patient and a dimension of 4.5 to 2 centimeters with a resection margin of 1.5 centimeters, sizable portion of the tongue is going to be lost.
Okay.
So if the sizable portion of the tongue is going to be lost, our protocol is to reconstruct.
Right.
So again, there are the surgery that is contemplated for this patient would be, let's say, a hemiglossectomy. Maybe it will extend more depending on the MRI if it is crossing the midline. So depending on that, the anterior two-third part of or most of the anterior two-third of the tongue would be lost. One.
Right.
Two, he or she would require a tracheostomy prior to the procedure.
Correct.
As a routine, we would be doing a tracheostomy in these procedures, plus a bilateral neck dissection.
Correct.
Whether the clinic, though you've mentioned that the nodes are palpable on one side, conventional, these lesions, we would have a bilateral neck dissection done. So that's a protocol for surgery, and reconstruction would be contemplated by using a free flap. We usually use a microsurgical free flaps for these patients, and we have various options. Personally, I use a lateral arm flap. There are people who would prefer a radial artery forearm flap. So between the two, that's it.
Okay. Okay, sir. So, and now just tell me, do you look at the number of beds available in the ICU when you do this kind of surgeries? Would you be putting this patient for a couple of days observation, because these are surgeries with a lot of morbidity and mortality? So any such plan you have in mind?
So this patient will definitely go into ICU because there is an airway issue, and there can be a compromise on airway. Okay. So our hospital, fortunately, we've not had problems regarding admitting patients and managing ICU and shifting beds. That is usually done by our customer care, and we have not had a problem.
Correct.
It could be a hiccup for 24 hours, but that we can manage by putting them into some adjoining room where intensive management is feasible. Correct. So ICU management is required, but we've not had that problem because our hospital, unlike others, I won't say it's a COVID hospital. We were only taking in malignancy patients with COVID would be admitted. We have very few beds for COVID were earmarked.
Correct. So I move on to Dr. Rajkumar Shrimali. Raj, have you given any neoadjuvant chemotherapy to these kind of patients? Initially operable, but somehow or the other, there aren't any resources left in your center. You are trying to push back the surgery by, let's say, 6 weeks, just because there is no availability of bed or staff. Is there any possibility these patients under the NHS gets some form of neoadjuvant chemotherapy as a bridging option?
So is the question pertaining to this patient, or is it a more general question?
No, pertaining, I mean, not this patient, it's a general question, yeah.
Okay, so when it comes to neoadjuvant treatment, obviously there are two types of neoadjuvant broadly. We can categorize them in two groups. One is the kind of treatment that includes systemic cytotoxic chemotherapy. Now, correct, chemotherapy has a side effect profile where people can get neutropenic, their immunity goes down, and they can have problems. Correct. They can be sick, they can get dehydrated, they can get all kinds of problems. And these, we have tried to avoid them as best as we can. We have tried to make it less intensive. Correct. And we have tried to keep, because if these people get this treatment, A, there is the issue of treatment capacity, and B, once they get the treatment, if they have side effects, then they need to come in and attend the accident and emergency or the casualty department. And most of the casualty department was kind of the casualty was divided into clean and green and red zones, and most of the casualty was for COVID patients. So we tried to reduce this as much as possible, and we used it only in situations where the neoadjuvant treatment was actually going to be life-saving. It was going to make a difference between cure and not cure. Okay, and not for the sake of improving survival by 2 or 3 or 5%. So that is one group of it. The other group is neoadjuvant therapy in hormone-positive breast cancers, yes, where neoadjuvant treatment used to be cytotoxic. If they were hormone positive, they would get hormones. With prostate cancer, the radical radiotherapy or the surgery was, well, we don't use neoadjuvant hormones with surgery because it gets technically more challenging. But certainly with radical radiotherapy, they went on neoadjuvant hormones, and the surgery was usually standard treatment is going with radiotherapy 3 months after starting hormones. during the peak of the pandemic, these patients were delayed. They stayed on hormones, and then the definitive treatment was delayed by 6 months or 8 months, depending on capacity. And then there were some radically treatable patients, stage 3Bs, who with lung cancer, who the standard of care is to give them radical concurrent or radical radiotherapy depending on their age and fitness. And there were patients who were EGFR positive, and they went on TKIs instead of going straight into radical treatment. So there is obviously this hormones and EGFR TKIs or targeted therapy where the side effect profile is different, and these people are not likely to get neutropenic and get admitted into hospitals as emergencies. So these went on, but cytotoxic chemotherapy was reduced.
Perfect. In fact, Raj, this has been the practice in our center also, in most of the centers in India. I mean, we are following the same practice because now we have some very wonderful oral preparations which can actually replace the intravenous cytotoxics. And you correctly said that in the process of giving somebody neoadjuvant chemotherapy, if I give a basket of drugs, 2 to 3 drugs, which are very, very toxic, they can lead to a severe myelosuppression, and your main aim or target of doing a surgery can be further delayed. You can actually lose the patient also, because you may not be able to offer this patient an admission bed once the patient comes back to the emergency with the complication post chemotherapy. And there are certain tumors which are very, very responsive to targeted therapy and hormonal agents. And I think the evidence is enough that we can actually use these drugs in a neoadjuvant setting and still get ample benefit without compromising the efficacy and, of course, the survival and the treatment aspects. So thank you, Raj, for this opinion.
Rakesh, you have to rush a bit because you're losing audience.
Okay, sir. So we move on to...
As a request, please take the opinion of the chairman and co-chairman also.
Yes, sir. I will be. Yeah, so I'll take opinion on this particular aspect.
Can I make one comment with relevant to the earlier case?
Yes, sir.
That probably that would not be appropriate for this patient in particular. I mean, just for the sake of the audience, to give a neoadjuvant for oral cancers, oral CA tongue, for that matter.
Yes, sir.
Okay, you carry on. Thank you.
Right. So we move on to the case capsule 3. This is a CA lung. This patient had a lesion in the upper lobe, right side, and the patient also had a couple of lymph nodes in the mediastinum. And the patient had a background history of hyperlipidemia and COPD, but the patient was otherwise stable. ECOG performance status was 1. ECOG is a validated scale to make out the general well-being of the patient, how the patient is actually performing on the day-to-day activity part. So therefore, this is a stage 3A adenocarcinoma lung, non-small cell lung cancer. And now my question to Dr. Jibok would be, Jibok, before the COVID had actually set in, what was the treatment plan for stage 3A lung cancer patients in your center?
Am I audible?
Yes, yes.
So for this patient who is having mediastinal node multiple, I think 2 stations are involved, it says.
Yes.
2 enlarged nodes, right? So basically in that case, it makes a stage 3 and 2 disease. So that patients are usually candidate for concurrent chemoradiation. That means radical concurrent chemoradiation, this patient.
Correct. And when we talk about concurrent chemoradiation,
yes.
Can you just elaborate? There are a lot of people who don't understand the tricks of radiation. There are different ways to radiate a patient. You have an IGRT device, you have an IMRT technique, you have a 3D CRT, you have a conventional cobalt. In a very brief nutshell, can you actually explain what are the tricks and which one would be appropriate for this patient? And of course, the cost implications.
Yes. So basically what we do, we give radiation is known as the teletherapy, that is the giving radiation from the outside, high energy radiation. So it is either by isotopic machine, mainly cobalt 60 machine, or in our center we use high energy X-ray. Most of the sensors are having Linacs now, including our government setups now, linear accelerator, which produces high energy X-ray. So for conventional, as you have mentioned, so basically what we do is we give radiation beams from different sites depending on the technique, so that we can encompass the tumor volume inside it. so that, and it is usually given in a fractionated basis, and in this, as this patient is quite a advanced stage, so it is usually given in standard for lung patients. We give a 30 fractions, as we were mentioning that weekly 5 fractions. So it takes around 6 weeks. So 30 fractions in 60 gray, that is conventional fractionation, that is 2 gray per fraction. Along with that, we give chemotherapy to basically radiosensitize the tissue, and the efficacy of radiation increases when chemotherapy is given concurrently in a lower dose, but in a weekly basis with radiation.
Perfect.
Now, regarding treatment, it is that if you see the conventional, which is old technique, which is based on mainly X-ray. So at that time, no CT scans were available. So based on the X-ray was the only thing to see where the tumor location is, or the bony landmarks. So based on the bony landmarks, markings were done. And based on these markings, usually suitable fields are to be given, usually one anterior and one posterior field, so that we can encompass the entire treatment volume, entire tumor, what we can see in X-ray. But the problem with that is, as you can understand, that we cannot shape anything. We just have to do a box as per the marking, and that box should encompass the tumor, as well as particularly for lung, we know the tumor moves along with the lung respiration. Yes. So we have to take into account that the tumor may move during treatment. So we have to take a good amount of margin above, below, in both sides, so that you can encompass the entire tumor within it. The problem is that you are irradiating the normal lung also with that.
Perfect. I'll just hold you right here.
Yes.
Deepak, so what is the best technique for lung tumors? Something which will not allow additional rays to follow normal structures exactly on the tumor it falls. What is the best technique?
So best technique is to go for 4D CT scan based simulation and image guided therapy. That is, in a daily basis, we have to do CT scan and or other imaging modalities, and to check whether the tumor is in a location of our field. And usually, depending on the proximity of the normal structures, and intensity modulated treatment or IMRT is a good choice.
Perfect. So Deepak, be there on the day, and I would seek the opinion of Dr. Rahul Roy Choudhury, convener for tonight's program. Rahul, in a stage 3B cervical cancer patient, do you contemplate surgery if Rahul is around?
I am around. So basically, no. Stage 3B would require concurrent chemoradiation, and that is what we have done.
Right. Yeah, okay. So we go back to the chairpersons, two very senior professors of radiation oncology, Dr. Gautam Bhattacharjee and Dr. Anup Majumdar. So I will seek their opinion. Dr. Majumdar, I think there were some guidelines issued by Association of Radiation Oncologists of India that in case you're not being able to deliver concurrent chemoradiation, you can go for a sequential therapy. Was anything said or something shared at that point of time due to COVID?
Actually, there are certain guidelines, but it varied from center to center depending on the situation, manpower availability, patients being able to come to the center. So they were comfortable with some sort of oral medicines and short course radiation. That was the basic guideline.
Correct. Okay. And Dr. Bhattacharjee?
I also agree with Anupda that because of the constraints, many patients in different hospitals, different spheres of hospital, they are not able to reach the hospital because they're quite far away and they have to come daily. So we have to accordingly go by each case, and chemotherapy was definitely a hindrance for such patients. So we often used to forego chemotherapy and just depend on radiation at the moment. But then sometimes again, depending on the situation, if the patients were quite, they were staying close by and they could get along with treatment, confident, and general good performance, we used to continue both chemo and radiation together. But by and large, each case was taken to customize each patient.
So if you only contemplate giving a patient radiotherapy, I mean, you are treating the patient only with monotherapy, that is radiation, would you actually ask the patient to undergo a RT-PCR test for COVID? Yes. Or you can start?
Very much so. We did a regular procedure, a process that where we were We had to go for RT-PCR before starting the treatment. And in our centers, we normally never did any RT-PCR in between, but sometimes we used to screen them. The medical officers used to screen them periodically. Even the technicians were screening them. If they found any symptoms, then they had to do repeat the testing in between. Otherwise, we kept on with the treatment without doing any RT-PCR. But initially, we had to do RT-PCR.
Correct.
Few centers are doing on a weekly basis.
Correct, sir. We move on to Dr. Rajkumar Srimali. Raj, have you encountered any such instance where a patient was recommended for a concurrent chemo radiation, but you ended up giving this patient the sequential therapy, radiotherapy followed by chemotherapy?
Radiotherapy followed by chemotherapy is not commonly used.
Opposite. Let's reverse this. So let's reverse the sequence.
Yeah. So sequential chemotherapy followed by radiotherapy. In the context of COVID, no. If the definitive therapy is radiotherapy, chemotherapy often adds to the survival, adds to the results on its own. No, we didn't do that. That was not an option during the COVID times.
Okay, so a stage 3 lung cancer patient in your center undergoes what treatment on a priority basis?
So it's either radical concurrent,
okay,
or is radiotherapy alone.
Correct. So for the people
sequential is not being used during the pandemic.
Correct. And suppose this patient undergoes some amount of response, do you put this patients on immunotherapy like durvalumab, because immunotherapy at this point of time actually prevents the occurrence of relapses or disease progression by huge extent. Did you practice that?
Yes. So in order for patients to get durvalumab, they need to have a positive PD-L1 test of at least, so it has to be more than 1%. That has to be known at diagnosis. Then they have to have a CT scan, which has to be done within a month of finishing radiotherapy.
Perfect.
And we have to see non-progression.
Correct.
So if the existing tumor is slightly bigger, that could be because of acute inflammation. As
Correct.
long as there is no new area of disease, as long as there is non-clear progression, they would be eligible for durvalumab, which has to be started within 6 weeks of completion of treatment.
Correct. 42 days. Yes.
It is a difficult treatment to get through. I mean, single agent pembrolizumab for PD-L1 very high is often given for 2 years, and patients sail through that. But durvalumab is often very difficult for patients.
Yeah. So
Rakesh, can I actually ask a question of
Yes.
Dr. Srimali?
Yes.
I'm just slightly curious as to what your protocol is or was while the COVID was in full, when you had such high numbers of COVID, and perhaps you had patients with advanced ovarian cancers coming to you. Did you shy away from neoadjuvant chemotherapy of carboplatin paclitaxel, or reduce the dose, or just ask them to come after 2 weeks? Or what did you really do?
So neoadjuvant chemotherapy in
the setting of advanced, highly advanced, or high volume disease.
In the context of ovarian cancer, they were used. They have to be used.
Okay, no, that's fine. Just a clarification. Thank you.
Yeah, so some important recommendations were given by American Society of Clinical Oncology during COVID times. And these are anti-cancer therapies should be continued as planned in times of COVID-19. You just don't stop it if you think the patient is going to get a huge amount of benefit from chemotherapy. Clinical decisions should be individualized. In case a center is affected by COVID, then you can relocate yourself to another center, or you can postpone your chemotherapy cycle by about 2 to 3 weeks. Preferring oral therapies over IV chemotherapy would decrease the frequency of clinic visits. So whenever there was an option of replacing an IV with an oral treatment, and it was not compromising on the efficacy of therapy, we used to do that. And we have done that very often in colorectal cancers, lung cancers, and breast cancers. This ASCO organization, as well as the ESMO, recommends liberal use of growth factors. Growth factors like GCSF actually doesn't allow the WBC count to fall after cytotoxic chemotherapy. It's given as a primary prophylaxis, and if it comes down after chemo, it's given as a secondary also. So we practice more of primary prophylaxis rather than secondary prophylaxis, and less frequent dosing interval had to be chosen. So my question to Dr. Rajkumar Shrimali once again, Raj, how expensive is growth factors, and are you giving growth factors on a prophylactic basis to almost all kinds of regimens which are cytotoxic?
No, not with all types of regimens. No.
Okay, the ones which are very cytotoxic and they have a chance of causing neutropenia more than 10 to 15%, I think they would warrant these kind of prophylactic medication. Yeah. So, Raj, one more important question for you. One more important question for you. How do you place immunotherapy? Do you give immunotherapy on a routine basis? There is somebody who has unmuted his microphone. Therefore, yeah. So, Raj, do you recommend immunotherapy for all patients? I mean, the ones who qualify for an immunotherapy. It's not that the ones who don't qualify, we don't recommend that. But
so immunotherapy has been continued during the pandemic, but the dosing had changed. So we used to use pembrolizumab 3 weekly. Now we give a higher dose once every 6 weeks. So
correct.
The number of visits to the hospital and the number of contacts has been halved. With atezolizumab, it was a 3 weekly regime. It's changed to 4 weekly as well. Nivolumab used to be 2 weekly. That has changed to 4 weekly. So yes, the immunotherapy has been continued on a less frequent basis at a higher dose to maintain the treatment intensity.
Yeah, many of us had this initial notion that immunotherapy actually would be a big hindrance to COVID patients. And if you give immunotherapy, that would actually flare the COVID status. But honestly speaking, if the immunotherapy is really essential for patients, we actually continue immunotherapy. And as Raj said, we increase the frequency from 3 to 6 weeks, and we just increase the dose. That would actually reduce the number of hospital visits for the patient, and you don't compromise on the efficacy. So that's
actually, sorry, can I interrupt for a second?
Yes, yes.
The indication of immunotherapy was expanded. So in the context of lung cancer, people with a PDL1 of between 1 and 49%, they used to get immunotherapy as a second line treatment after first line chemo. And the NICE then under specific COVID guidance made that available first line. Just to sort of increase the progression-free survival and to keep people out of hospital in order to reduce the use of cytotoxic therapy. And again, apart from immunotherapy, I think osimertinib was moved to the first line setting by NICE as well.
Correct.
Again, because it has a much longer progression-free survival.
Correct. So just for the people
Rakesh, sorry to interrupt. I just
Yes.
want to ask Raj a question which arose in my mind is those patients who are on immunotherapy and suppose they're stuck with COVID and post-COVID, they come back and they try to join the treatment. Would you advocate the same dose schedule and continue the same treatment? Considering the fact that people do get immunocompromised after COVID also. So how would you take the patients post-COVID at all?
Yes. So I've actually had patients who tested positive and they were well. So we were able to continue once they were clear. So that's one group. And if a patient actually becomes ill and gets admitted into hospital, needs ventilation, etc., then these patients essentially we are allowed a break of only 12 weeks. So if somebody has a break of longer than 12 weeks, then we cannot continue. That is because because the standard practice has been copied from the trial protocols. The breaks of only 12 weeks are allowed. And if somebody needs a break longer than 12 weeks, then they usually do not come back with a performance status of 1. Immunotherapy is not indicated in patients who are performance status 2 and above.
Thank you. I get it.
Yeah, so what Dr. Rajkumar Shrimali highlighted, you have a biomarker, especially for lung cancers. If the biomarker has a certain value, you have the option of giving immunotherapy at certain lines of therapy, and the threshold has actually come down. What used to be a higher value to mandate immunotherapy in first line, that value has actually been made a bit lenient so that you can use these drugs a little earlier. And it is very important that those patients who have gross lung injury post-COVID, sometimes the immunotherapy also causes a bit of changes in the lungs, and there can be certain cases of pseudo progression. So those are the elements where it's very difficult to take a call and differentiate the activities of immunotherapy, how much immunotherapy is contributing compared to what happened with the patient in terms of COVID affected lungs. So we move on to the next slide, and this has this NHS guidelines regarding prioritization of patients who are candidates for systemic therapy, that is chemotherapy or hormonal therapy or immunotherapy. So they have given a lot of priority to patients who are getting treatment with the curative intent, and they are getting, and those patients who are not getting curative treatment, just a life prolongation treatment or non-curative therapy, they are giving less preference. They have actually given a lot of preference to patients who have a huge tumor burden and would respond to systemic therapy very, very quickly, because if you can reduce the tumor burden, the patients will have a better quality of life. So we move on to the final case of the evening, and that would be a hematological case. And for this, the person has stayed quite for long. We would seek his opinion. So this is a 21-year-old newly married lady who presented with an acute onset gum bleeding. Just imagine, 21-year girl who has just got married. 6 months down the line, she presented with an acute onset gum bleeding, menorrhagia, pallor, and weakness. On doing a peripheral smear, blast cells were identified. So my question directly to Dr. Demallo Bhattacharya: how will you manage this patient, Demallo, starting from investigations to management, and of course the challenges you will face at every point of time? So Demallo, are you there?
I think Rakesh, you called Demallo. I think maybe he's check or something.
While we are waiting for Demallo, can I request?
Hello, hello, am I audible?
Yes, yes, you're audible.
Yeah, Demallo,
okay,
take this question. 1 second. Raj wanted to highlight something. Yeah, Raj. When Demallo unmutes his microphone, a lot of other sounds come. So yes, Raj.
Sorry, can we go back one slide?
Can we go back one slide? Yes.
Yeah. So this list. So whenever we book anybody electronically for chemo, we used to get this as tick boxes, and we had to choose which category the patient falls into. And if the patient did not fall into any of those categories, then we could not proceed with chemo. So this is the most important thing that we used during the pandemic. Thanks for putting this up in a slide.
Yeah, so it's an automated system. If the patient doesn't qualify in any of these categories, the patient don't end up getting something. So emotion doesn't really play too much of a part in that case. Thank you, Raj. So Demallo, this is your case. Starting from investigations to management and the hurdles you're going to face to handle this patient. 21-year-old newly married.
Yeah. So the everywhere. Hello, am I audible?
Yeah.
Yes, you're audible. Yes.
Yeah, yeah.
Audible, but
So this is a very difficult.
Unseen. You must see you. You're unseen.
Okay. Hello, huh. So this is the problem with many of these leukemia patients, because leukemia patients, they require a lot of care and close care. So every day, or rather, hello sir, on kora the video.
Now it's okay. Now it's okay.
Okay. So every moments or every hours is important for this type of patients. So I'm coming to this case. This is actually, I told Rakesh to frame this case because it was a real patient. So last year in April or May month, real life patient. So
Demallo, you have got muted once again. Can you just?
So this patient, yeah. So what happened? This patient, so initially she was treated in Birbhum, some interior districts, with definition of diagnosis of iron deficiency anemia, like any young new female anemia patients. So what was wrong with the patient was that it was not, obviously the symptoms were not alleviating. So the patient came to me, and this was the I did the basic investigation CBC and advised transfusion. Patient's blood group was O positive, so it was quite easy to go with that transfusion. But problem is that when I was to do a bone marrow study, so bone marrow is a cornerstone diagnostic procedure for this patient. So bone marrow now where to do, because many of the hospitals, small scale nursing hospitals were shut down. Patients have some lack of funds, so she could not go to big setups like Apollo. And another thing is that the flights were closed initially, so the samples for immunophenotyping, which we collect from the bone marrow procedure, could not be dispatched. There are 2 to 3 centers in Kolkata which do the in-house testing, like Tata, Apollo, and other few ones. So that was a big challenge during that period. So somehow I could make the diagnosis of AML. You know, AML is a most dreadful leukemia or blood cancer. So what happened after the diagnosis? After the diagnosis, the patient came into went into another mess, because we are losing time, and patient have lack of fund. The husband lost a job or temporarily for the pandemic, and the initial cost of treatment is around 2 to 3 lakhs approximately in semi-private setting. In total, in bigger settings like Apollo or Tata, it will be on the higher side. And the government medical college, there are 2 hematology departments. One is NRS and another one is Medical College Calcutta. Medical College Calcutta was exhausted because of the COVID declaring of COVID hospital there. Many patients were not willing to go, so all pressures were on NRS Medical College. So it was practically one pandemonium. So very difficult for this patient. Somehow we could manage with a lower grade chemotherapy for this patient. We did not go for the textbook chemotherapy, because we have to customize the treatment.
Perfect.
So I went for some bridging like of chemotherapy, like low grade chemotherapy, which will not cure the disease but somehow restrict it or control it to some extent for the time being. So I personally took this approach, but there may be difference of opinion. And another challenge was that I told already transfusions, because AML patients require frequent transfusion. So donors were exhausted, fund was exhausted. So after that, COVID situation become a little bit better the next part of the year. So that time we could give proper chemotherapy. So for the time being, we have to go for just a bridging like of small scale chemotherapy.
Correct. So what I understand, Devmalu, because AML mandates very acute and intensive chemotherapy, cytotoxic chemotherapy, you try to buy some time by giving a less intensive treatment. And then once the COVID surge actually came down to an extent, things became much more easier for you. You started the intensive therapy. So this is the message everybody should get, that when you're treating a leukemia is a bad disease, will not give you time. You just do not isolate the patient or desolate the patient. You have to be with the patient. You buy some time by giving some form of therapy, which will have some kind of impression on the bone marrow, to kill some of the cells, may not all the cells. And then once the time comes, you go full blast at the bone marrow. So Devmalu, your opinion regarding vaccination in hematological malignancy and in transplant patients?
Yes, for bone marrow transplant patient, it is definitely no, because the immune system is destroyed or reset. So there is no benefit of giving any kind of vaccine. So after transplant is over, 6 months after transplant or 6 months to 12 months, we give all other vaccines the patient received in childhood, like polio vaccine, diphtheria vaccine, chicken pox vaccine, everything we again reuse. So same thing applies to COVID.
Okay.
But regarding leukemia patients where the immune reset is not there, there are particular chemotherapy like rituximab or like some strong chemotherapy. In those patients, vaccination will be not beneficial.
Yes.
But some patients who give who is on oral chemotherapy or say bortezomib, those patients can be given vaccine.
Correct. So there was a very important message given by the various oncological societies, that patients who are on rituximab, which is an antibody directed against CD20, you should not immediately give this patient vaccination. You will have to wait before you start giving this patient vaccine. So Raj, are you there? Rajkumar Shrimali. Devmalu, you can just mute yourself. Yeah. Devmalu, kindly mute yourself. Yeah. Raj, your opinion regarding the role of vaccination and the timing of vaccination for patients undergoing systemic therapy and radiotherapy.
Yeah, at the moment we are advising everyone to get vaccinated as soon as they can. That is all I can say.
Yeah. So if the patient has got a chemotherapy, let's say a docetaxel after after one cycle of chemotherapy, there is a possibility that there could be a neutropenia developing after docetaxel. You have
Yeah.
taken adequate precautions. And when you place the vaccine, do you place the vaccine exactly in between two cycles, or you just look at the nadir values of the WBC, and once you think they are normal, you give the vaccine?
I mean, if a patient comes to me who has not been vaccinated, then I
Yes.
would advise them to take the first dose before starting the chemotherapy. And for the second dose, I would ask them to take it usually 3 or 4 days before a cycle.
Okay.
But having said that, I mean, that is more out of, I would say, what we think is right.
Okay,
There is no evidence in this setting. And lymphocytes, most chemotherapy that we use does not actually have an impact on lymphocytes.
Correct.
Apart from temozolomide, that comes to my mind at this moment. So it's more based on what I feel is right rather than what I know is right.
Correct. And if you come across a patient who probably qualifies for those pneumococcal vaccines along with this COVID vaccination, so you might be coming across these kind of patients. So they take the vaccines almost one after the other, successive days, or there is a gap between two vaccines. Any such guideline in your NHS?
Pneumococcal vaccines have all been given by the time they come to me, so I have never had to face this.
Okay, perfect. So yeah, okay. And we had spoken about vaccination strategies for surgical patients. So we come to the final slide of my presentation, not the final slide, it is the penultimate slide. The people who are actually the healthcare workers who are offering the care to the COVID affected patients as well as the cancer patients, I think they are very, very essential, important. And in order to maintain continuum of care, there are certain guidelines given by various international bodies. You need to take care of yourself. So I'll go back one by one. I will ask Dr. Gautam Bishar, sir, how have you kept yourself stress-free and preventing a burnout in these situations? Because this thing is not going to end. It is probably going to hang around for one more year. So how do you manage yourself with same amount of exuberance and excitement every day? How do you manage yourself? Stress busters for you.
That is a very interesting question. We had our doubts, especially in the beginning. There was a phase, possibly in April, May, when there was a cycle where half of us were on duty and half were not on duty, considering that we were anticipating somebody might fall prey to COVID. And we did fall prey to COVID also.
Correct.
So there was a period of stress. So I had to run my department. We did not shut down any patient care, though the number of patients in the initial phase had fallen drastically. But after that, when things opened up, then there was a lot of discussion whether we should be in hospital if really we don't have not operating. Let's put it that way, or an OPD. So this sort of argument carried on amongst the juniors, and some of our juniors were put on COVID duty. So there were certain areas of stress.
Correct.
Possibly it was not as much as I would gather in the other hospitals where they had been converted into COVID hospitals. So that way, because the numbers had reduced, though our number of patients, our operative numbers were, in fact, we have done more surgeries, what the data has said, than what we did in the non-COVID period, saying that that was not affected much. But there were issues where medical people became COVID, and we had to have other people working with us. So it was stressful. Now, how did I tackle with it? Well, I don't know. Just as like a normal human being, I think we ourselves are in a stressful situation. Whether it is cancer, as physicians, we are always under a stressful situation, and I don't think the cancer oncosurgeons or oncologists, in fact, have an extra bit of stress. It is the stress is there among the whole medical fraternity with all that is going on and all that we do, and we are considered frontline. So, well, we have to accept that and live with that. I think that's.
Gautam, I have a question to ask you.
Yeah.
The thing is, when you're in OT, the head and neck surgery and doing repair work, it may take hours. It takes 6 to 10 hours of time. But inside a closed atmosphere for such a long period. And it's true that the patients, they do undergo anesthesia before they put on the OT table. But sometimes there have been mistakes, and it has been found, much to despair of surgeons, that after the OT, they were found to be positive. My question is, all this while, when you're in the OT for 10 hours or so, do you have stress inside that, you're inhaling the same air and something can come up in future?
Yeah, I think,
That's my question to you. What are your inner thoughts?
That stress is in the subconscious level, because we were testing everybody and presuming that they were COVID negative. So the patients were COVID negative. The problem occurred, some of the staff were COVID positive.
Okay.
So that created a problem, and there was no way we could define as to who was carrying a COVID, virus at that point of time or not, because we were only testing people who were in direct contact. The protocol: 15 minutes exposure, not wearing masks, etc., etc. Only those group. But there were people who were getting exposed outside, who were traveling in through whatever mode of transport or through their family members and coming in, because what had happened in our hospital was that initially they were giving us leave if you were COVID positive. But later on, they said, no, you have the staff, the class 4 had to stay within the campus, which was causing another stress. So, there were a lot of complex situation which was handled day to day. I think initially the whole administrative setup and the physicians were under sort of stress. But gradually there was a level of acceptance, and everything so-called, unfortunately, we did not have anything very serious during this past 2 years as such.
And I suppose you get used to the stress also.
Yeah.
No, I would Gautam, I would just pitch in for a point, because Gautam is in a elite hospital also with Apollo. I have seen Onubda work in the situation, in COVID situation in Nightingale like that. I would like to ask his experiences, not of the big hospitals, but of the centers like Nightingale Hospital or a smaller center where the situation was not that right as the staff, and the arrangements are not high. Onubda, what is your opinion in working in the COVID times in a private center like Nightingale?
Actually, it was a bolt from the blue initially. Actually, there was lockdown and the centers, the outdoors OPD clinics were closed. The staff's strength was becoming 25-30%. And we were not sure whether by coming to our clinic or attending the ward, we'll accumulate the disease and get back home and infect the others. So there was initial phase of hesitancy, and few of our colleagues around too got infected. So naturally, that point of time, we are not tested very regularly. There is no vaccination. So there is very uncertainty prevailing for a quite long period. So still now, the same phase of uncertainty is there. Naturally, we are going to a clinic, but not sure whether we can come across a patient who are COVID affected, asymptomatic, whether we can carry infection from them, and our few colleagues were succumbed to the disease. So this sort of uncertainty was there. So it is still now, the things are not normal. That much I can say.
If somebody else to chip in, that's okay. Otherwise, I think I will call this panel discussion off right now.
Devjani, are you there? Devjani?
Okay. So we have had a fantastic and a very stimulating yet a very practical discussion on how to manage different kinds of cancer patients during this COVID pandemic. This can actually act as a template so that people who are very fresh into practice, they can actually imbibe this information and that can be implemented in their future practice. So thanks again to all the panelists, and thanks especially to Dr. Rajkumar Shimali. He's 4.5 hours back, but he had to wake up after a afternoon siesta to be on time. And thanks to the organizers, the chairpersons, the office bearers of this wonderful body on wonderful forum. And thanks to all the other participants who logged in on a Sunday night to listen to some very important information. That's all from my side. I hand over the microphone to the chair.
Yes, I must congratulate Rakesh for conducting such a good panel discussion and seminar. So it is because of you that it was so nice. And I also thank the panelists for taking part and sharing their experience in the tough situation. I also thank my co-chair, Dr. Gautam Bhattacharya, and I am also thanking the organizer for allowing us to share our experience in this COVID time, and also some little bit of experience in management of cancer, particularly in COVID time.
Thank you. I would not like the word organizer. We are all colleagues in NRS Medical College, so there is no organizer over here. It is a body of experience association. We are not organized. We are part of the fraternity.
Yes, yes.
We are part of the fraternity of our college. That brings us together, actually. Rahul, is it okay?
Somebody has to.
মানে শোনো, এবার আড্ডাটা মারো দেখি অনেকক্ষণ হয়েছে।
আচ্ছা গৌতম,
না বলছি যে somebody has to lead the torch, তাই না? সেখানে you are the torch bearers, you are helping us integrate us.
My relation with Gautam is very, very sweet from the days of 1972, because we were doubles partner. We won table tennis a lot of times.
We went to ISI, Indian Statistical Institute once, represent our college, and we played with against ISI. Babulal and myself were all there.
You are all partners, doubles partners. So
and
it was a lovely day.
We really had very memorable times, so we can't forget those days.
So thank you very much. Enjoy yourself. Thank you for teaching. The first,
thank you.
I was taught gynae the last date. Before that, I was taught psychiatry, medicine, and now I'm learning cancer. Thank you very much. It's a learning process for me. But please, a request. Samne Robbar, Raj, you must convey this message to Kaushik also. Samne Robbar, 7 o'clock, everyone has to be there, because we are having a midterm musical conference. All the people will be there from the whole part of West Bengal and UK also. They are participating. Everyone, please participate. You will have a wonderful evening that day.
So what time? 7 o'clock?
7 o'clock Indian time.
হোয়াটসঅ্যাপে বা ফেসবুকে পাঠানো যাবে?
হ্যাঁ যাবে তো সৌগত, it will go Facebook live, WhatsApp live, সব হবে।
What is the maximum limit for participants? কজন participate করতে পারে?
Up till now we have had 33 participants.
মানে ইনভাইটটা যদি হোয়াটসঅ্যাপে যদি পাঠানো যায়, যদি রাকেশ আমাকে বা আপনারা কেউ যদি পাঠাতে পারেন, তাহলে এখানে আমি যাদের সঙ্গে আমার যোগাযোগ আছে পাঠিয়ে দিতে পারবো।
রাজ, কি তুমি ইয়েতে আমাদের এনআরএস এর গ্রুপটাতে নও, আছো না নেই?
না, রাজ is not there. You need to put him into the group. Yes.
Add করে দাও না, and please pass this invite to everyone ওখানে, যে কোনো আছে, please pass it. It's going to be a memorable evening, I suppose. So thank you very much for every Shogata. Thank you again for helping us to organize this. Shogata is one of the pillars of our program, because he always does the main work is being done by him.
গৌতম দাকে অনেকদিন পরে দেখলাম।
হ্যাঁ,
গৌতম দার সঙ্গে আমার রেগুলার এমডিটি অনেকদিন পরে দেখলাম।
That's right.
গৌতম বিশ্বাস দা।
Right.
So thank you, Saurabh. Thank you, everyone. Devmallo, Rakesh, thank you, everyone. Thank you, everyone, for everything.
Thank you, sir. Thank you.
Thank you for this opportunity.
Thank you, sir.
Gautam, thank you.
Thank you very much.
So good night.
Good night. Good night. Stay safe, all of you.
Have a nice day. Have a nice day.